We are going to talk on the actually basic principle on DSS. Then let us discuss about the DSS as basic principle. How are we to do what? Of course, in recent days it is noticed that somehow DSS is in a back foot and your PF and other things are coming up. That is true. Change is the only truth, but basic principle is try to understand. Certain conditions is going to help you also. Stable type of token flexors, even it is much better. Stable type of flexors. So before going for the fixation, you have to demarcate which category of patients actually is a good candidate for DSS and who is not. Nowadays, probably most of the surgeons they are going to prefer going for the intercapsular flexor with DSS also. DSS with derotation screw. That is going to give because it gives control collapse. Now it was more applied for token flexors. Even initial period of time in 1980 onwards in this junction, people will try to apply the DSS in the sliding system. Basically, what is this? SSS, sliding. Basic principle is sliding, compression. Dynamic compression is basically applicable here. Control compression. And this principle was applied in all type of token defects earlier. But it is true the sudden is going to fail. Particularly those very unstable level flexors. Reverse oblique, not a good idea. Flexor which is having a lateral wall combination. A flexor having medial integrity is lost. So there is not a good option. But initially people try to address all the token flexor DSS. That is why there is a failure and shifting to this the intermediate fixation device. Basic thing. At one point. Number two, again, before intermediate fixation is coming into play, DCS also was the alternative to address these situations where DSS is not going to give good result. So DSS applied everywhere, failed in unstable type of flexors. People shifted to DCS. DCS still good, particularly where there is a combination of medial valve. Medial, posterior medial combination is very important, integrity. Because this principle of your DSS is basically what? Control collapse is the principle. Another, what is the basic principle here? Tension. Correct. This tension band, correct. So what is the principle of tension band?
Converting the destructive forces into compressive forces.
Sir, if an implant is applied on the tensile surface, it is converting the tensile force into compressive force.
Always true? Provided the medial wall is intact. So it is same principle applicable there in case of your patella, another your oblique flexors. Same principle. Here you must have a integrity in the concave surface. You are applying to your tensile surface is the surface where all the deforming forces are working. So we try to address it. So that is why plate should be placed on the tensile surface to address the counteract the deforming force working over there. Basic principle. Yes, that is true. But this is going to help you on those cases where you are having a good contact in the concave surface. But if there is no contact, it is going to collapse. Cut through another problem will come up. That is why the integrity of the posterior medial conveyor is very important. So third basic things are there. There is basically tension band principle. Tension band principle applied in tensile surface. Integrity of the medial wall is very important as well as lateral wall also. It can be applied in the combination of lateral wall, but you need a support, additional support. Yes, it is supposed to be. You can apply in lateral wall. Particularly, again, you have to give additional plate to support a trochanter, commited trochanter. So, integrity of the lateral wall is important. If not, then you can take the help of the additional plate to support the lateral wall. Okay, so but medial wall continuity is very important. Otherwise, it is going to fail. But in certain situations, if you are doing so, but if you are not happy with the medial wall, then you can go for even grafting and other thing also to maintain the integrity in the medial wall. Understood? So that these are important thing to understand. Now let us talk about the components. What are the things? This is
Recharge screw.
this is plate. Again you have this one screw. Now I already discussed certain points about this. What is the length of this area? What is the diameter? 12.5.
12.5.
What is the length?
22.
22. ठीक है sir? Number 2. Again you suppose to see, this is a very important interesting thing. Plates are having in short barrel and long barrel. Selections of the short barrel and long barrel depends upon the
Neck length.
neck length. Correct. He is right. Neck length. Neck length means if the neck is long, then necessarily the recess screw is long. If the necessary screw is long, then you can have a long barrel also. But if the neck is short, and if you apply long barrel,
Collapse will not occur.
then what will happen? So
Collapse
it
will
is
not
almost coming to this approximation. So it will not prevent. But compression is what? One device is this, another device is this. There is compression and deflection here. Yes, compression. Compression. So if it is stuck here, then how it is going to help you? No, it will cut through, will be there. So that means a part of this CA should be made free, so as to have a good excursion. Now, how much it should be there in between the two threaded part and this? What is the size? 12.5. And pitch 3 mm.
Yes, 3
3 mm pitch. This is almost 22. 22. That means this part of your should be there in between the tip of your part of the barrel and base. So this part is going to help us with compression. And how much should be there inside the barrel? Again, this is an important thing. See, there are two things. Supposing I am applying this device like this and keeping the plate just like this.
No, sir.
Just keeping it in plate like this. And then if the force is working, it is stuck, it will not allow it to go. Got my point? That means it indicates that a certain amount of your research screw should be inside the barrel to have effective here. Inside the barrel. See? So if it is like this, so I am okay. Device is this. See, there is a little bit of angulation sort of thing. But it is essentially inside the barrel. But it is not sufficient. So if they are sufficient, then it's not going to play, it is stuck. Yes, sir? So that is why a standard part, minimum part should be inside the barrel. So minimum part is almost around 22. So roughly you can say 22. Again this is 22, roughly. So it is supposed to have. So calculate yourself. Now what is the size of the barrel I am see? Clear, this point is clear to all. This is a very important thing because you can mechanical thing you have to understand, otherwise it's not going to help you serve the purpose. So certain parts should be inside, certain parts should be let free, certain parts should be threaded inside. This is clear. Again little bit of the plate. The plate is coming actually what?
38 for long barrel.
One.
Two, three things are variability there in the plate. Though these look same. One point is that this barrel normally
135 degrees.
135 degree. What is CCD?
Caput column versus angle.
What is the normal angle?
So 130 plus.
Yes? This is not fixed actually. Though we
130
take
plus
the
minus
length.
5.
115 to 130.
Certain China you may see in the X-ray also somebody is having almost straight sort of. Young man. An elderly person having angulation is less. This is a true picture. It is seen. Probably you have seen in the X-rays also. You can notice that the younger man angulation is a bit less. Almost sometime. So, are you going to fix the same plate in the same condition? No. That is why. That is why this plate is also coming up here. The idea behind is that you are supposed to have the central. In the model version, central. CCD and weight bearing angle are same or no? What is the weight bearing angle? weight bearing angle. The two things I am talking. One is CCD, caput column angle. Another I am saying what? Weight bearing angle. Weight bearing angle is what? Weight bearing angle is the axis. You see, it is almost coming position. So almost straight shorter. Weight bearing. So this is around 150 degree. 150 degree. Almost. So that means the angle which is coming from secondary and weight is coming, no? This part is coming. Most of the weight is borne by this part, posterior part of the pelvis. And this is coming like this. So this weight bearing angle is not same with that of your CC. So this is around 150 degree. So ideally, I supposed to place the implants in the axis of weight bearing. So that is going to be. So if you are going to do so, that means the angle should be what?
Less than 1.
Almost 150 degree. But why you are selecting 150 degree, not selecting? The question is that if you are going to give a plate like this, almost this, 150 degree,
Cut out.
not the cutout, then the entry point will essentially come down.
Fractures.
So it will be, say, to place the place, it is, if the angle is like this, then I have to have a entry point down below the lesser offender. So this is the area which is going to go in fact. Are you getting my point? Yes, sir. That is you have. But ideally, I am supposed to place the plate in the axis of the weight bearing. Weight bearing and CCD angle are not same. So that is why you are selecting the plate not corresponding to the weight bearing angle. Rather, we are selecting 150 degree, most of it 10, but not always true, because idea behind is that I supposed to place the guide wire in the center. So in the center means this is the center, supposing this is your neck. So my idea is that I have to place the plate in the center. Center is both AP and lateral view. So it says that it is supposed to be bull's eye. What is bull's eye? Bull's eye means you are targeting in the bull target. Then you have seen the target here, bull's eye. So your idea should be, so AP view is the center, lateral view is center in the head. So this is the idea. So that is why people sometimes do not use this. Rather they wish to place the guide wire in the center, then you calculate it out. Now how much plate I supposed to give? This is more ideal situation. Because the angle, are you getting my point? Yes, sir. So this is we are taking, which we are going to fix 135 degree. But ideally what? Ideally I supposed to place the guide wire in the center AP and in the center lateral view. So this is called bull's eye. So bull eye. So I am getting hit here. So necessarily this angle will be not same in all the person. All the person. That is they will be very there. So that is why reverse things are actually more scientific. Means you are trying to put the guide wire in the center of the neck, center of the head, bullseye. Then you calculate how much angle actually is. Then select the plate reversely. Ideally. But acceptability is there. Posterior inferior is more acceptable to variable because there are long area of cut through. Posterior inferior is more acceptable. Variability is there, but ideally is your central. Yes, sir. That is. So step by step, if you are going like this, now these are the principle. Any question? Mane parts, technique techniques you these are the principle. Principle. So patient is in the supine position like this. Patient is in supine position. Supine position, yes, neutral. There are few more things I supposed to tell you. One or two things is that the reduction is must. So you see, plate is a fixed one. This device is very fixed. So essentially to place a fixed, this is a fixed. You do not have the variability here. So essentially you are supposed to have a good reduction before putting. Without getting the reduction, you cannot do it. The one point. One is you must have a very good reduction, and from the reduction point of view also one can know what is the stable and unstable by Evans classification. That is one. Reduction is there, everything is fine. And I did not mention about the certain variability. I said certain variability. One is Garby angle. Certain variabilities are then the plates are coming in long or short. So long and short decide on what? Huh? Though there is very much, it says 2 screws and 4 screws are hardly make difference, almost same. So longer plate is not, but osteoporotic bone, if the extension is down below, probably it is where you are going to apply longer. 1 point. Selection of the plate. And just 2-hole screw and 4-hole screw hardly make any difference. 1 point. Length sometimes depend on the osteoporosis and also extensions in the selection of the plate. One is your, I mentioned about the selections. What is the length should be there? I told you. I told you 2 things. One is what is length of this barrel and what should be selected. I don't know. Again I said it is a long one. Again you see the holes are, sometimes holes are oval. Compression. Another is something round. So round and oval can be selected if you want to additionally give compression there. So here you can apply a compression DCP principle here also. DCP principle here also, if you are going from the oval one, so additionally you can give intraoperative compression at the flexor side. Flexor side. Got my point? 1 point. Additional point is that the again interesting point. See, the holes are not the same length. Why? So if there is a same length, there is a stress riser. So they are mislead. So this is coming like this. See, they are not same. Same true for DCP also. You look at the DCP, they are not in the same line. They are coming like this. So this is going to help you in the sense that they are on the same line. So stress riser is not here. So you are this is going posteriorly, this is going anteriorly, this is going posteriorly. That will gain better process and reduce the failure rate. Reduce failure rate. Compression screws again hole can be applied to give additional compression resistance. We can exert intraoperative compression at the flexor side by what are the techniques? How you can give intraoperative? See, the barrel is going to help you for subsequent compressions by the muscles power. If the contraction is there, it will going to give compression at the flexor side. That can be done later on. But intraoperatively, how you can give compression at the flexor side? One, that you release the traction. That is going to give a compression at the flexor side. 1 point. Number 2, this is called compression screw. This is again coming into 2 length, 29 or 36, something like that. So this depends upon the length of the screw also. So depending on this is called compression screw. But compression screw is not a mandatory one. But you can intraoperatively give compression deflections. So intraoperative compressions can be given with the help of releasing traction. 1. By this compression screw. 2. By the oval hole. Yes, again is going to help you with compression. Got my point? So these are the techniques by where you can give compression at the flexor side intraoperatively. So intraoperative compressions can be applied by various techniques. By selecting the plate, by applying this, by releasing tractions, these are techniques. Okay? Again I told you one thing there, while doing the fixation, plate is already introduced. Then the last screw, the last one is the first to be applied. Why so? So, that is very important. See, while applying this, so this is the thing we are going to apply. Okay, we are doing it. Then a plate, sometimes this, because of this your weight, there is every tendency that angulation will be posteriorly. Sometimes you may need a support there. So muscle is relaxed under anesthesia, and gravity will try to make an angle posteriorly. So while doing it posteriorly, if you do not correct it, probably plate will be like this. Plate will be like this. So you are keeping here, so angulation is there, the plate will be there. So essentially you try to bring the plate in the center. So that is why last screw is the first one to start. Again, earlier days they used to give one single cortex. This concept is no more applicable nowadays. You must have seen the old cases, old DSS where they used to last to half, single cortex.
Stressful.
But this is not applicable nowadays. They are saying that this is same. You can give full bicortical fixation there. Okay, so that is why this screw should be started in the last, and you can maintain the plate should be it should not be offset. It should be corrected. Okay, sir? So how to start now? So these are the principle. It should be adhered in all the cases where you are going to select what implants, what should be size of the length of this screw, what should my plate will be, where I am going to place the guide wire, that is very important, and subsequent things are there. The patient is under anesthesia in the supine position. What next?
Place the patient on a traction.
Traction table, this patient is traction table, reduction. So reduction should be confirmed by the CM beforehand. And in initial period of some time, people used to pass K wire anteriorly or posteriorly, mounting, so as to maintain the reduction. That is the additional thing can be done. Particularly elderly patients, the muscles are very relaxed. You reduce it, again it will come back. But it is always mandatory to maintain the reduction during the fixation. So for this purpose, otherwise somebody is going to support it, or you can apply various K wires also around anterior posterior. That can be done for PFN cases how we used to do. Same principle can be applied here also to maintain the temporary reductions during the process of fixation. So that is a technique. Otherwise somebody is supposed to support it in here, because this whole technique, whole process is to be done in the reduced step. So you do not try to do the reduction after fixation, after applications of the implants. It will be another disaster for you. So you maintain the reduction first. You can take the help of the K-wire also sometime to maintain the reduction. Now what is the incision?
So you palpate the
GT.
Extend sir 5 to 7 centimeters below sir. In the shaft of femur.
Yes, sir. That is true. What next will coming to you?
So the tissue deep fossa sir.
Deep fossa. What is the deep fossa known as?
Tensor fossa.
Tensor fossa. It should be cut. Now what next coming to you? In front of you?
So vastus lateralis.
Yes, that's right. So if the vastus lateralis, what you can do with the vastus lateralis?
So there can be two
We
things.
can split it or we can go
Now
through the
this is the picture, no? This is the picture. Patient is there. This is tensor fossa. So your tube is somewhere here. This is your base. So tensor fossa. If you you have to cut. This part will be cut.
Yes, sir.
What next coming?
Vastus series.
Lateralis. Now lateralis, what we can do? Vastus lateralis. Okay, your vastus lateralis here. Here. But two things you can do. Vastus lateralis, two things you can do. One, you can two things. Yeah. Sometimes people are going to give a incision like this. So as to directly you are hitting the bone. But while doing so, you essentially cut certain vessels also. So you have to cauterize this here, control it, because externally your ring is somewhere here. Or one can do what vastus posterior end. You can put a lever over there and reflect it. While reflecting, you necessarily detach this your origin of vastus lateralis. Reflecting. Yes, sir. So incision, tensor fossa lata, vastus lateralis, two techniques. One, you can cut this middle. Can be done. Particularly your thin build person, probably this is more easy to do. Cauterize the vessels which is coming, otherwise they will be bleeding. Or you can reflect the muscle anteriorly. While doing so, you have to detach the muscle origin. So you have the attachment of the vastus lateralis here. Then you can take the CM, take the help. Now first thing is to go for the guide wire fixation. So in guide wire fixation, what you are going to do? So in guide wire fixation, now this is soft tissue dissection is over. Reduction is maintained. As I said, you can maintain the temporary reduction with the help of the K-wire, putting anteriorly or posteriorly also. So middle part is remain vacant so that you can work out. So this area where there is the attachment of this here, what? So this is the just opposite to lesser trochanter, you can find out the place. This is invariably the guide entry point is this. Entry point is essentially this. So it is said that thumb weight. Sometimes you can take the thumb weight, take the elbow thumb weight and you take the entry. By entry somehow 1 mm or almost at the level of the lesser trochanter. So you initially do not put the guide here. So you try to break the wall here with the help of your drill bit. With the help of it. So if you try to put the guide wire first, what is the problem you are facing? This is a guide wire here. The problem is that the guide wire is a bit somehow malleable. It may sometimes be difficult to penetrate this area. This area, okay? So essentially, this area should to be started with a very particularly strong bone. Try to take the help of a drill bit. Make a hole here. So initially, you can start in the point like this. Suppose it is the guide wire there. Now entry. Then again you have to angulate it. First take this maintain. That is going to help you one way that the guide wire is not essentially giving load to the guide wire. So if there is more resistance in guide wire may deflect. It may not be in the same track. So that is why take the help of the lateral wall to break it with your drill bit. That is essential. So do not start the guide wire. Invariably you will find it may deflect to some extent. So it will be difficult to maintain it. So initially start it. If the hole is big also nothing to worry because you are going to make the hole bigger later on. Somewhere. So it will be here only, the hole is big, nothing going because you must necessarily have to make the hole bigger. So if you are making a hole also, but if you need to move upward and downward, hardly matters because you are essentially going to make the hole bigger to accommodate the plate later on. Yes or no? Yes, sir. So that is why next in here you are putting the put it there. Down. So in this area two things can be done. Anti-version to be careful. So if you are thinking that my anti-version is not corrected, so anti-version corrections can be done interpretively if you make the limb internally rotated. So it will be horizontal. Two things are happen. See, after reduction, you can make the neck horizontal, or you can keep it like this. So if you make the hair horizontal, that means you are already doing the limb internal rotation. So internal rotation will make the length almost parallel. Yes? Otherwise, you have to think that I have to correct this. So this is almost like this. So immediately you have to go down below. So correct the anti-version. So your aim is here. So this is parallel to the bone. Yes, then I have to be like this to maintain the what? Anti-version. So initially you go. Now halfway you wait. Take the AP view. From this here you can have a trajectory that my axis is going superiorly, inferiorly or central. At least that idea you can have. Or you can mount another guide wire over there to minimize the radial exposure, my radiation exposure. I can put a guide wire over there above and see if my trajectory is going to hit the superior part or inferior part or in the center. One point is clear. In the AP view, my trajectory is like this. Now what next? It is lateral view. Yes. So lateral view again, if you are going halfway, then you are not hitting. I know that my AP view is going to be in the central part. Then my job is only to manipulate for the, or whether it is anteriorly or posteriorly. Next job. Next job is anteriorly, posteriorly, then you have to take the lateral view now. From the lateral view, you know that my entry point is anterior or posterior. So from this point, you can only manipulate anterior posterior part. So that will help you, because anterior posterior part means playing the blade either this or this, but not this. So this is already been fixed by the AP view. In the lateral view, I can do what? I can go for posteriorly or I can go anteriorly. By my trajectory in AP view is fixed. Okay, sir? So that will minimize your radiation here. So you put it now. Now it is said it will go up to the extent of the neck. Somebody used to go up to the cerebellum also. So why it is so? So that it doesn't dislodge the process of your rimming and other thing. Clear? So they are saying that it is better to keep a bit high up, lock it here, so that it doesn't displace. So that is another way. Now my job is what? This is okay. We have confirmed that my guider is in a bullseye. Bullseye. Everything is fine. Now next thing is you go for the rimming and other thing. What is the rimmer known as? Why it is called triple rimmer? 1/3.
8
This is
12 mm.
This is
23 mm.
Why? Why it is important?
To accommodate different parts of the
Different parts. Most important the angle. This should be accommodated. Supposing if you have done the rimming here, so next job is to go for the rimming. Now you have to adjust the length also. There how much? If from the guide wire you can calculate what is the length. You can mark it that my how much I supposed to go with the screw. I'll tell you. Where I supposed to land up. Subcondylar bone. In the subcondylar bone, two things are there. One is osteoporotic, one is non-osteoporotic bone. It is said in the osteoporotic bone you got 5 mm. And in case of strong bone you can go 10 mm. But essentially supposed to lock at the subcondylar bone area. So it is a very strong bone. Where if it is locked there, displacement chances is less. Displacement chances is less. That is why you are supposed to lock it. Got my point? Then next order is rimming. Now you have to do the rimming. Then this part supposed to flux with this. This is important, because if you are rimming up to this level and this hole is not big enough to accommodate this part plus, then it will lying outside. It is not going to be answered. Correct? So that is why rimming is a must. And while doing rimming, you are supposed to intermittently take the C-arm view. Why it is important? So look at how it is going. One. Number two. At one point, sometimes this guide wire may stuck in the heel. And while doing the rimming, this guide wire may also move upward. So intermittently you are supposed to see. Very important. Sometimes it may stuck. It happens many times. It may go inside. That is another disaster. So you are supposed to look at it in between and see. And again you have to lock it there. Up to subcondylar bone, as I mentioned, 2. 1 osteoporotic, 5
non-osteoporotic
10. Clear? Now what next job is mine? This rimming is done.
tapping.
Now is tapping. Now in tapping process, two things are coming up. One is very osteoporotic bone. There is no point of tapping. Very osteoporotic bone. While doing it, how do you know the patient is having very osteoporotic bone? While doing this, he will tell you how much resistance you are feeling. If you are feeling too much resistance, you are feeling that the bone is very strong. But if it very easily it is going, you know the bone is very soft. So if it is soft bone, I believe there is no point of doing the tapping. But in case of strong bone, you are supposed to need. You are supposed to do the tapping. Why tapping is important, I will tell you. Now, okay, everything is done. Now you are supposed to calculate the length what was going to be. So calculation going two techniques. One technique you can subtract the part which is lying outside with the another guider. Another guider they are going to be same thing. That's why from this point you can make out. Or otherwise you can, again I do a technique here. You can put a guider inside. And the hole is big enough, so you know where the second guider is, and then you can take the artery forceps here, clamp it, and this is direct one. Two techniques. So you can put another guide. Hole is big enough, so you can put the guide wire reverse here, another guide wire, anything else. Then you can take the head measurement here. So this is directly going to tell us what is the length of the screw. Simple. Now wash it away, the debris will be there. So wash it away, then I'm going to put the screw. So while the screw you see, there are two things is there. Look at this screw, see, this part is flat. Yes or no? Yes. This is round support, this is flat. And my placement is hard. Look at the plate. Look at the plate. This is a plate where this is going to help you. So essentially my end will be that plate should not like this, but it should be like this. It may be a little bit of this way, that way, that will be adjusted, but finally while you are doing putting the screw, so essentially it's supposed to be in this plane, because it is barely big like this. So if you are putting like this and you try to struggle, you cannot put it. So this simple thing, but you have to understand that it is flat part should be like this. So your next thing is that, then and then it will go. Otherwise if you are leaving it like this, you struggle, it is not going to help you. You cannot do it. So but if you know, then you can do it, put it there, then you can, somebody used to go like this or that way. After all you have to do it. So finally, so you go for this is one, and to displace this, people used to use this also. You can take the help of this. Okay, sir? Before putting this, they find that the guide wire is coming out. What to do?
By this screw, recharge screw, by applying recharge screw in the opposite
direction. Our instrument is there, centralization.
Yes,
Centralization. So because see, you can just arbitrarily cannot put the guide wire hole. So if you next time if the guide wire is coming out, and you try to put the guide wire without taking any guidance, then it may go like this. It may hit it into, or it may go like this. It will not be central. So if it is not central, then it will be again, it is not fit. So you can take the help of what?
Recharge screw.
Recharge screw. Recharge screw. You can take a centralizer also there. You can put the guide wire inside and put the guide wire inside again like this. So tap it, fix it. Then you put the screw inside. Finally supposed to be here. So now one point is there. Particularly in a hard bone, while you are locking, now it is stuck strongly. And if you try to do more rotation, here what is going to happen?
Sir.
The whole fragment may move. This is another thing. Now it may dislodge because it is very tightly fixed over the tip. We have to adjust. Are you getting my point? This is a very important thing. So you will find that finally it is locked, and you are going to tighten it more. Instead of the screw is propagating, so the whole fragment may rotate. So you may take the help of bone holding or something else to counter it. Sometime to hold it and then it go inside. Or otherwise you have to reverse it back. One thread to make it horizontal. Final part is very important, because if your angle plate is like this, and if you are like this, after all the plate, while you are inserting the plate, it will be like this. So in the final area, see, while it stuck this strongly, and if you try to do the rotation, the whole fragment may move instead of the screw going inside. So that is why sometimes the K-wire is very important to fix it, or you can hold the bone. Hold the bone with the bone holding so as to, otherwise if it is very strong, very difficult, it's better to reverse it one thread. So to make the thing like this. Otherwise it may go. It may, you try it, it is going, but it is not going. Actually whole fragment is rotating along with the screw. So this, the rotation of the proximal fragment along with this screw means displacement, basically displacement. So you are losing the reduction. So this is a simple thing, but this is also going to, final reaction may not be satisfactory. So final, as I said, inside, then plate is being fixation, as I mentioned already, first start here. Then you can do the reduction, traction screw release. Then you can apply the compression screw so as to have a intra-operative compression reflexor side. Intra-operative compression reflexor side. Additionally, can be applied the oval screws, or you can apply the other devices for supporting the lateral wall. Lateral wall. Plate. Taconic supporting plates can be applied over here. So this is the basic principle of it. Now what we are going to do post-operatively. So post-operatively it is dependent upon many things. One, during time of operation, how are your feeling of fixation? This is one of the very good surgeons can have a very good fixation. And what about the integrity of the posterior medial particularly? What is the conditions of the bone? Osteoporotic, non-osteoporotic. Now next is the analysis of the X-ray with the TAD. This is very important. So if your TAD is less than 25, this is a good sign. That means I am in the correct. So how much you can allow the patient to move after operation, dependent upon the many things. Do not go that the patient can be started. Sometimes you can allow the patient to full weight play. Sometimes you do not. So it is not a universal thing. It is a tailor-made. Tailor-made on what basis? This basis. One, where my head is locking. Tip. Am I in the subchondral bone support? I am getting it. Am I in the central part? What is it TAD? What is the conditions of the bone? And what is the condition of the posterior part? All depending, you have to calculate it. Then and then, depending upon which you can be partial weight, full weight or non-weight bearing. So this entirely depends upon so many factors, not single factor. So this is how. Any question?
Thank you, sir. Borthakur.